pass them to Dave, or we'll have some time during at the end of the session as well to go through some of those questions. And that is all from me. I'm going to hand it over to you. Thanks, Dave.
Thanks, Ash. Good morning, everybody. So I'm also here in Shep. So thanks, Ash, for doing acknowledgement. So I'm going to share my screen here in a second, and we're going to bounce back and forth between a couple of things. So first, and you'll see me looking because I have multiple screens set up, so it makes this a little bit easier for myself. I'm going to talk through a little bit about the process first, and sort of how we got to where we are with the vending machine for people who might not be as familiar with the project. And then ultimately, I'll share some of where we are with the data. Not finalized data. We still have to do some cleaning, but ultimately where we're up to roughly the middle of last month as we come into our final month, where one machine has actually been pulled from its location this week. It's actually sharing the office here with me at the moment. And then the other machine will be pulled later this week before they go to their second year locations. So let me get this up and running for myself, and then we'll get going. All right. So hopefully everybody can see that here in a second. Perfect. So like I said, today we're going to talk a little bit about the STIX project, and ultimately what that looks like as a novel approach to STI testing. And ultimately, I want people to think about throughout this of other applications for this kind of idea. It's not exclusive to STI testing. There's a lot of things that can be done in this. We know that you can get mobile phones from vending machines. You can get period products from vending machines. So there's a lot of things that you can do with this type of technology. So understand sort of the implications and maybe what some of our barriers and limitations are to it will ultimately help, I think, expand this type of concept as we move forward and try to look at other ways to advance healthcare options, especially in rural and regional areas around the country. So thanks, Ash, for the acknowledgement again. First, I also want to acknowledge some of our collaborators for this. So within our team here, and it's actually a whole team effort. So our director, Professor Jane Tomney, our other manager, Anne Marie, Ben, who is currently an acting manager, and Kim, who has helped me with this, as well as Ash and the rest of the team. That's really done a lot in terms of bringing this together, our community involvement and engagement of making sure that the people on the ground, that the people that were going to ultimately make this successful wasn't the vending machine, it was our partners. We might have come up with the idea and said, can we put it somewhere? But if everyone said no, we wouldn't have a project. So a lot goes out to them. Also Professor Kit Fairley at Melbourne Sexual Health, and then Deb Williamson, who was the director of the Doherty Institute when this project started, Tara Lynn and Professor Jane Hawking from the University of Melbourne School of Global Population Health, and as I said, all of our host sites and the communities that made this possible. So when we think about some of the reasons why we need to come up with innovative solutions, these are not going to be new to anybody that lives in a regional town here in Victoria or ultimately any state and most countries. So we know that accessing appropriate services can be challenging. There's a myriad of reasons of why. While there may be one thing that you can point to for your individual community, ultimately there's going to be compounding factors that impact this. And so I've just listed a few things here. So again, we know access with dwindling GPs in regional areas means we have longer wait times, few or no specialist services. I mean, we now have some sexual and reproductive health hubs that are popping up. Lack of public transit to get to appointments. And then some of the other bits, like, again, retention. We have an aging workforce. People that we do have don't always stick around, a bit of a revolving door. And then you have things like personal barriers. So again, stigma, the concepts of you know, a lack of privacy. And even though we know that healthcare professionals take privacy and confidentiality extremely seriously, it's still hard to sometimes overcome people's perceptions that in small towns things may get leaked, and ultimately things can happen, especially if you have a cousin, auntie, uncle, brother, whatever, that works in a GP, and you're seeing files and a friend goes in there. Information can get leaked. We know that it does happen, but not as often as people think. And then again, we know cost can be a major concern for people. So when we came up with this idea, we were trying to figure out a way that we could make STI testing accessible. And when we look at making it accessible, one of the things was putting it where people, again, had access to it. So trying to find places that were going to work for individuals, trying to reduce the cost as much as possible. And in order to do this, we sort of followed this little flow chart here. And I know most people here are probably from Victoria, so they're probably laughing about the map. This was a slide I used for an overseas conference where people might not have known the states and territories. So bear with me on that one. So we started every site with the exception of one. So you'll see on the subset down here, Victoria, where you have Mildura, Swan Hill, Chuka, Shep, and Wang. All of those sites had pre-planning meetings. There's actually a sixth site that was introduced later on, Mansfield, which did not. That's a bit of an exception for a couple of reasons, but I can talk about that a little bit later. But ultimately, the idea behind all of this was engaging with the community members, specifically the professionals in the community, to see what we needed to do, what would be suitable locations, how information was transmitted, like health promotion information, what referral pathways might be there. And then we think about what those partner organizations can do and how they're going to be how they're going to help support this initiative. Because ultimately, so if you don't know much about Search and where we're based, we have staff in Shepparton, Wangaratta, and Bendigo. So again, Shep, Wang, and Echuca are pretty convenient. When you start to get to Swan Hill and definitely Mildura, it's a multiple day trip with driving hours and whatnot, that if the vending machine runs out of tests, it's going to take a couple days for us to get there to fill it and come back. So it was really important to get those partner organizations on board to support this. And then you could see the rest of the pathways generally followed between a couple of meetings. We tried to hold a professional soft launch, which was often in smaller areas, a bit amalgamated with the community launch, to give people an opportunity to come and just have a look at it in case they were curious. As you can imagine, there wasn't heaps of community people that came through. It was mostly professionals. And then we take some of that community feedback, and I'll talk a little bit about that at the end, because some of the feedback, as I'm sure you can imagine, with everybody asking for surveys these days, it's quite challenging to sometimes get people to want to actually fill in surveys to give you said feedback. So that's sort of where we're at with that. The pilot started in early 2022 from a conceptual perspective. And then the initial launch was in June of 2023. So like I said, we're right at the 1 year mark. The reason why we're actually technically about a month over the year mark is with Christmas and a few other things. It took a little bit longer to move some of the machines around to make it work for different services. But effectively, we're saying it's a 12-month pilot. There were two machines, as you can see, ×2. One originally sat in the Loddon Mallee region, which went up from Echuca, Swan Hill, Mildura. The other one, Shepparton, Wangaratta, and then ultimately down to Mansfield. And the idea was to try them in different types of locations. So what we found throughout this was some of the preconceived notions that we had about where they should go sometimes didn't quite work as well as we would have liked. Such as public toilets, because the size of the public toilet might not be big enough for this machine. It's fairly large. A community health center, but then again, if you're already going to a community health center, you probably are already going to access health services. So a lot of these things had to be taken into account when we were looking at what we were going to do, and some of the communities again came up with some really good ideas, and we were fortunate to be able to try them in a few different locations. So we did trial one in a community health location. A few were in libraries. One was in two were in dedicated youth services. One ended up being accessible 24 hours a day, 7 days a week, because it was placed outside, and it hasn't been stolen or vandalized, which is brilliant. So those are the types of things that we tried to do was, I guess, get a feel around these different communities around what some of these options might be, knowing that, for instance, here in Shepparton and even Bendigo, when we were looking for year two, there's not necessarily always a good place to put a vending machine this size. I mean, realistically, it takes a bit of space at the moment because we're using a floor mount as opposed to mounting it to a wall so they could be mobile. And unfortunately, in the 60s, 70s, 80s, when a lot of these buildings were built, nobody envisioned that I was going to want to put a vending machine there, so they didn't leave me a little nook. So we sort of had to work with what we had, and some buildings just didn't quite work out. So even if they were great ideas, logistics ultimately prevail. That's probably the biggest thing I think around how the pilot was conceptualized. So what I'll do is there's a I'm going to show you, hopefully this will work. There's a short video clip of roughly how the machine works and how you engage with it. And then I'm going to pop out and actually go through why we set up the questions the way we did for data capture and ultimately what the process actually looks like. Since this has been edited, it doesn't give you maybe a full idea of every aspect. So let's have a crack here and see if this will play. There is some music. I don't think I shared the music, so if you can't hear the music, you're not missing a whole lot. All right, so I'll stop sharing this for a minute. Any questions at this stage while I'm working on just getting the other slide deck up?
Maybe a quick one from me, Dave. Were you guys pretty apprehensive for putting the STI vending machine outside for the graffiti and the stealing and that kind of stuff?
They're insured. So we ultimately expected that we actually expected that something would happen. I'm actually surprised that nothing has. I will say though that the place where it is outside at the moment, which is Mansfield, is probably the safer of many of the communities that it would have been in, that we could have put it outside. The original place that it was idealized for Shepparton, and I was pretty confident that if it was going to get damaged, it probably would have been here. I can say that because I live here. But ultimately, if you know Shepparton or don't know it that well, in the middle of town, there's a little bit of a bus interchange. There's a public toilet right next to that, and you have the male toilets, female toilets, and then there's a parent's end that parents don't go in because there's other activities that take place in there that's not parenting. So we were going to use one of those rooms because we didn't have to worry about water being sprayed on it when they were hosing down the public toilets. Unfortunately, just due to a couple of barriers with the council, we weren't able to make that happen. But yeah, the short answer is we actually expected something would happen. We had lined up wraps to have on the outside of it. We thought if we were going to put it there, we were actually going to build like a plywood case around it. Like we had a whole bunch of ideas that we absolutely needed to, because realistically, the only thing that would impact the use of it is if someone smashed the screen. Everything on these are replaceable. So realistically, it would have been out of commission until they sent me a new screen from the UK where the machines were built. But yeah, it was definitely something that we were expecting to happen. So to make it through an entire year with nothing is actually, I don't know, maybe a testament that people were like, maybe this is a good idea and we shouldn't stuff it up.
There's just some questions in the chat too there, Dave, around how many kits fit in the machine, and also how do you manage to keep the kits in an environment that's cool enough if the machine is outside?
I will come to those questions in just a sec, because in this
Great.
slide deck, I talked through that. So thanks for those. So I'll go ahead and share this now, and we'll cover that in just a second. So hopefully now you can see the screens. Oh, maybe if I actually click share, you can see the screens. There we go. Now you should be able to see the screens. Perfect. So effectively, I'll just go through briefly what these screens look like and ultimately how we why we chose what we chose for them. So these are actually the live versions of the screens that we sent to the developers to replicate them. So again, we played with having screensavers and a whole bunch of other things, but ultimately we're like, we just need to be honest about what it is. Let it there, let people see it, and you're going to either choose to use it or you're not. There's no point of trying to hide it because that just reinforces the stigma that we're actually trying to move away from. So it tested for chlamydia, gonorrhea, and HIV. Originally, we were hoping to have syphilis included. A few reasons why that wasn't the case. If you're not familiar with how you test for syphilis, you do still need a blood sample. And the reason why we were working with Vigil, so Deb Williamson at the Doherty, was around how little blood could we realistically use to detect. And at the moment, we're working on it. I actually just had a meeting a couple of weeks ago on Victoria advancing this, but at the moment, we don't have the technology here to do dry blood spot for syphilis. So we still need venipuncture, which usually means we need, maybe 4 mils of blood. Ultimately, for the vending machine to work, we're talking like cap blood from your finger, so finger prick samples. So we're talking like 40 microliters, not 4 milliliters. You are not squeezing 4 mils out of any of your fingers and toes, or you're going to be very sore by the end of it. So that's ultimately why we had to remove syphilis in the first instance, because we just couldn't get the amount down enough to make it viable. These were the 3 priority populations, and these were set ultimately by Melbourne Sexual Health. So I won't go into the agreement on why we used them, but ultimately this is who it was intended for through the testing process of where the funding was coming from. Ultimately, we were happy that anyone used it. So when you see the results, you'll see that there's plenty of people that don't meet these criteria. And there's some information that we didn't collect on the screen to verify, but I know for a fact through some of the people who've returned tested it didn't meet these criteria. But again, fine with me, because it actually proves that everybody actually wants to use this type of technology. If you hit no on the screen, I actually think it comes, I'll show you here in a second what it does. There you go. If you hit no, what it did was we had a QR code that would just come up that you would scan it and it would take you to a website to where you could ultimately put in your postcode and find a GP. Now, we did have some questions at this point why we didn't list like a list of specific services. And the long and short of it is politics. Realistically, we can't prioritize one service over another service in a semi-privatized system. So therefore, we couldn't say this GP or that GP is better than another GP. So ultimately, it was you can go to a clinic and here's where you can find the clinics, or you can go to your GP. These are the 6 questions that we actually asked about on the screen. And you'll notice that the one priority population, which was Indigenous status, we didn't actually ask about here. So the only way to capture Indigenous status was if people returned a sample. Pros and cons to that, but ultimately we really wanted to minimize the number of questions that we were asking and the amount of time that somebody was standing in front of this machine. So again, age, postcode, assigned sex, gender. There's a reason why we asked both, my sex partners and last STI test. And I'll just show you what effectively the options are for those. So age, again, any age. Now, unfortunately, if you were 100, you couldn't use the machine. It only accepts 2 digits. Fortunately, no one over 70 that I'm aware of used the machine, so we're all right. Also, if you were under 16, it would actually tell you that you couldn't use the machine. And realistically, that just comes down to the concept of age of consent. And yes, I know in Victoria, we do have a 2-year rule under that, but there's some nuances there, and we had to be very careful in a pilot phase of what that would look like. And again, realistically, if they were 15 and put in 16, they'd still get a test, even if they then put 15 on their form. So there were ways around it. It was just something that we had to build in from a more of a, we'll say an ethics perspective, even though this didn't technically have to go through ethics at this stage. Postcode, simple. So assigned sex, we used sex terms. I promise I won't spend the next 40 minutes separating sex and gender terms. but we were specific on using sex terms and sex. And then in sexual partners, same thing. We're using sex terms. And the reason why we're using sex terms as opposed to gender terms here is because we actually care about anatomical parts for the purposes of sexual health. But we did still ask gender and I think I might have taken that slide out just to shorten this, but there was man, woman, and non-binary. So your gender terms as opposed to your sex terms. And then ultimately your last STI test, and this was more around knowing whether people are normally accessing other services. So if people are coming here saying they've never had an STI test, great. Well, that's useful to know that they're happy to go to this, but they're not happy to go to another service. So ultimately, once you filled it in, this is roughly what it would look like. Now, you had an option for what test to take. This is not what the machine actually looked like. This is what the machine was supposed to look like. And I left this in for a couple of reasons. One, because we had the penis test kit, the vagina test kit, the everything test kit, the health promotion pack. This was supposed to make life really easy and cut down costs on wasted products that, for instance, you don't need to give everybody multiple swabs if there's not actually a risk. So if you have a cis-het couple who's only doing, penis and vagina sex, you probably don't need everybody to have an oral pharyngeal or a rectal swab. We also had a health promotion pack. So if somebody wanted to use the machine, but not actually be seen to be getting an STI test, they could do that. The challenge, though, was when we got down to the point where we were trying to put in an Atomo rapid HIV test. So if you haven't seen one of those, look like this. They have to stay in this box sealed. So we couldn't fit this box with all of our other stuff in the same box. So unfortunately what we had to do, and you saw in the video that the person who did the test received 2 boxes. So we actually had to move to this style where we just had a penis test kit and a vagina test kit. Everybody got tri-site testing. Even if they didn't need it, the instruction said, if you don't practice any of these sexual practices, then by all means, you don't need to submit those swabs back. And we actually had quite a few people that only submitted 1 or 2 swabs back. So good to know that some people read instructions. And the only reason why we're saying that is from a cost perspective, every time a swab, the swab itself is a few cents. The flock swabs are rather cheap. But to test that flock swab is like $35. So therefore, if you're testing people that have no risk, it actually can run up a cost pretty quickly. And because this isn't able to be Medicare reimbursed at the moment, because one, Medicare has very stringent rules around self-testing, and there's very few options. They haven't quite made it that far with allowing this yet. And on top of that, we really wanted this to be accessible in a lot of our communities to where people might not actually have Medicare. So therefore, we self-funded this. So that's why we were trying to mitigate the cost, but ultimately we were going to pay whatever we had to pay to make sure people had the opportunity to test during the pilot phase. Then you would get the screen, and the reason why we asked people to verify is for one reason only. We didn't want somebody to go up to the machine and empty it just by pressing dispense, 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 and we'd be out of test. So each column, there are 4 columns in the machine. Each column holds 6 boxes. So ideally, there were supposed to be 6 penis tests, 6 vagina tests, 6 everything tests, and 6 health promotion tests. When we had to make the move to not being able to include the Atomo within our box just because we just couldn't make it fit, we then pretty much had to move, like I said, to the penis and vagina only tests. So there were 6 penis tests, 6 vagina tests, and then 12 Atomo, just to make sure that if we were dispensing evenly, there was plenty for everything. So ultimately, you can fit 12 tests realistically in the machine. Moving forward, and we're not making this change quite yet, we actually can move away from having a penis and a vagina test and just have a single test, because the only difference between the test kits at this stage, because everybody had 3 swabs, was that the penis test kit came with a urine pot. There's actually a lot of testing now for people with a vagina who actually can urine test as well. You don't actually need to do a lower vaginal swab anyway. And there's some research coming out of the UK where they actually found that people preferred to not do the swab, but to do the urine test. The test is sensitive to still pick it up. So realistically, we could move it down to 1 and just have 12 tests in there, which would actually be easier. And you'll see why that's the case when we get to the sort of the results. So that's the only reason why they put in the phone number. The phone number then sent a text back to you. So it'll text you a code, and then the code comes to your phone, and the message, I might be able to find it. It's been a long time since I've used my phone for it, but it said, it's what happens when you go on holiday and come back, because there's a lot of other text messages that have nothing to do with your work. There we go. Your code is like 5841. Thank you for testing. For a chance to win a $100 gift card, please complete our feedback form after collecting your test. So, and then there was a link to the feedback form. And that happened for the second half. We didn't have the link in the first half, but we did it in the second 6 months. You put the code in, dispenses your test, your 2 boxes, and then you pick how we did effectively, fast, and easy. This was to make sure that we at least gained some metrics from people around whether they thought that it was a useful tool. Again, not everybody filled this in, but most people did, which was quite handy. And then finish. These screens timed out after about 20 seconds, so it's not like it would just hang around and not reset if people chose not to do anything. But you could easily tap through and get through it quicker. No harm, no foul. Didn't bother us. But like I said, most people did actually give us some feedback. So what I'll do now is stop sharing that screen. And we'll go back to the other one. Any questions at that point? So I'll ask, sorry, the second question around how do you manage to keep the kids cool? Because they're dry swabs, there's actually no temperature requirements. The only requirement for the Atomo was something like they couldn't exceed, I think, something like 40 degrees or something. And realistically, we didn't have them in the hottest locations because, like I said, they're mostly in buildings, so it's mostly temperature controlled environments. It was something that we considered when they were outdoors, whether we would exceed that in some locations. But the only place that really was an issue would have been Mansfield, and obviously it's in the mountains, a bit cooler there. And so was there any tracking around times that machines were accessed? Yep, and I'll talk slightly about some of those stats in just a second. And any limited number of kits a person can access. Very good question. And the reason why, so another thing with that phone number, what that allowed us to actually do was put a time frame on. So even though we couldn't access the phone number, the machine encrypted it and could recognize if that same encryption factor came back through. So you could only access one test every 28 days. And Claire, you have a question now as well?
Yeah, just I'm wondering how you monitored and managed kit wastage, people that ordered kits and then didn't use them. And my second question is around the HIV test, which presumably was a point of care test. How did you kind of monitor results of that and get people to follow up? And you might be addressing this soon.
I'm not, but I'll answer that now. You can't and you can't. So that's the tricky aspect of any self screen. So for the first bit in terms of monitoring wastage, ultimately we know how many tests were returned and we know how many the vending machine dispensed. So the rest was waste. And you'll see that. Let me share the screen again when I get to the results page. And then in terms of it is the one thing that we don't know, because even though a large number of people didn't return the swabs, that doesn't mean they didn't actually use the HIV test. So we actually could be like sitting at 100% testing for some STIs, but that we don't know. And it's the one challenge, unfortunately, in this process so there's 2 other states that do Atomo only dispensing. So South Australia and Queensland had a pilot as well. They actually kept the phone number and followed up with them. But even then, they were still only finding like 30 or so % usage because people are saying, oh, I haven't gotten to it yet, or I'll do it later. And there's only so many times you can bug somebody to ask whether they've completed it yet. So it is the one downside of a self-test. That is the one benefit that had we moved or been able to use some type of like dried blood spot or something, we would have had a lot more access to knowing whether people actually tested for the bloodborne virus in this case. All right, so I'll share this again. All right. Nope, let's not watch video again. Right. So as of mid-June, this is where we were sitting in terms of results. Now, some of these are sort of generalized, and the reason being is because ultimately there will be some academic publications come out of here, so we can't give completely clean data, and we actually don't have entirely clean data yet. So we're still missing at least a month of results that I haven't been able to do since I've been away. But as of mid-June, there have been 163 tests dispensed across the 6 locations. That's a little lower than I would have liked, but it's actually not that bad when you consider that this is something that hasn't really been done before in terms of worldwide, to the best of our knowledge. This type of technology has never been trialed in a rural regional location. Ultimately, the ones that are in South Australia are sitting at like USA or Flinders. The ones that were in Queensland were at UQ. So we're talking about places where people have higher health literacy anyway, versus general community populations, especially in sometimes more socially conservative areas. So realistically, 163 collected is actually, we're happy with that. Returned, not as happy, because as you can see, only 29 had been returned at that point. This is a little bit lower than the numbers that TestMe, which is Melbourne Sexual Health's postal service. They usually sit in the mid 30s, whereas we're sitting around, or sorry, they sit at like around the 30% or high 20s. We're sitting at like the low 20s. So we're about 10% off in terms of returns. However, if you look at the positivity rate of those returned, 4 out of 29 is actually quite high. So we're talking 1 in 7. That's like 13% or something, 14% positivity rate. So I can only imagine what we may have actually gathered if more people had actually returned these tests. So the focus on year 2, so the vending machines will have a year 2, and the focus on that is putting them in locations and really trying to find ways to prioritize that return rate. What we started doing in the middle of this, so for our last two sites, I believe, one, we offered sperm key rings. If you've never seen them before, we have heaps of them. So ask us, happy to give them to you, or come to our conference. So we gave sperm key rings in one as sort of like a little gift in advance, hoping that's, I don't want to say bribe, but sort of like a bribe. And then in the other one, we offered a $10 gift card that all they had to do with returning their kit is just, because they were already putting their name and email and everything on the test kit instructions. And I can actually show you what the test kits look like in just a second. There's a little card that we put in there. All they had to do is put their name and email on that. And then when it went back to Melbourne Sexual Health for to be forwarded to the lab, they then sent us that little slip. So we've had a few people do that, but ultimately only a fraction, I would say probably only about maybe 15-20% of the people in the location that had the voucher actually returned a voucher. So even that wasn't really an incentive to get people to complete the test. Couple of reasons for that, but these are things that we're trying to unpack through our analysis, which I'm currently working on now. We've recently just done the interviews and focus groups for the professionals in these communities, and now we're trying to get community members to take part in various communities, or hopefully all the communities, to give us some insight into, had you seen it? If you didn't see it, where do you normally get your information? How did we miss you? And what would make you return it? Because obviously these couple of little things didn't. And I think some of it is, again, we're probably a little further ahead or a little further behind than other places who have been using this technology longer. So for instance, a lot of the things that we emulated here was based on some work that's being done in Southeast England, or I should say Southern England, since it's also in Southwest now, where they actually have something like a 65% or so return rate. Most people return their tests. But when I was working in NHS 10, 12 years ago, even then with our postal samples, we still had a return rate of at least 50%. And we've never had those numbers here in Victoria. So I think it's just a lot of it comes down to the promotion of sexual health. And as we start to reduce that stigma and people are more comfortable talking about it, that hopefully it'll improve some of these rates. But then again, I will also admit that those places, again, in the UK are also bigger urban areas. They're very progressive areas where RSE is probably in general a bit better. So relationships, sexual and sexuality education. But then also just, again, the promotion of sexual health services, there's just more options. So just some other key results here. So you can see here from assigned sex and assigned sex partner. This is why I said around having a single test would probably be useful, because there's actually, generally speaking, more assigned sex at birth female or assigned females at birth taking tests than assigned males at birth. That's pretty common in testing in general. So it's no surprise here, we've seen it. And it's funny because as we moved into June, the males actually came up a bit. So our last location has actually had slightly more males than females. Otherwise, this would be skewed quite a bit more the other direction. And we had a couple people who identified in this as intersex, and then a couple who preferred not to say. Again, because this is all self-report, can't verify. But again, if this is valid information, it's actually really, really useful in this space. Assigned sex partners, you'll see then again that of the 163 that were collected, about 1 in 7, 1 in 8 had a combination of male and female partners. So again, we're certainly targeting we're getting the right populations with this. Now, as I said, that one of our core populations that we were really trying to target was anyone identified as Aboriginal or Torres Strait Islander. We only asked that in the test kit when it was returned. So we know that there has been a percentage of a small percentage of people who had identified there that they were Indigenous. So again, that was also encouraging, and we are looking at putting the machine for a period in year 2 in a dedicated Aboriginal health service. So it'll be interesting to see whether the uptake is successful in that space. The other couple of key stats there that I've put on here. So for the last STI test, 2/3 were either more than a year ago or never. So we're actually getting people who are not accessing mainstream services regularly or ever, which is phenomenal. Some of the other information that we can track. So I think someone asked about time of day. As you'll see there, the next one down, so time access, 86% were accessed during business hours, and 10% of those were at the weekend. Granted, we didn't count the weekend as business hours, but we do know that there are health services that have weekend business hours. So realistically, we might actually find that only 4% roughly was actually collected outside of business hours. And that was one of the interesting things with the location with Mansfield being accessible 24/7. Very few people actually accessed it outside of 9 to 5, even though the machine actually sat in front of a window that was an office of a youth center that there was occasionally somebody working in, and people would just wave in the window, get their test, and walk off. So that actually wasn't the barrier. I was really surprised to see that we didn't have these 2, 3 a.m. Tests being taken when the opportunity was there. We also measured roughly, and again, this is all self-report, but we had the center of the postcode of where the vending machines were, and then we mapped the center of the postcode from where the people were collecting, and nearly 3 out of 4 were less than 49 kilometers. You would think there'd be a lot more less than that. I think it was somewhere around 50% were less than 25 kilometers. But there was actually a couple that were up to 200 kilometers away. And what we learned that some of those people were often people from Melbourne holidaying in these locations, accessing the test while they were there. Fast and easy, if you recall, those were the 2 questions that were actually asked on the screen. The mean for that for both of them was 4.8 out of 5. So for pretty much everybody that did this, they were saying it was a fast and easy process. Without going, like I said, specifically into breaking down the numbers even more, the most used machine was Mildura. Not too surprised. It's one of the, outside of Shepparton, it's the other big location that for population center that the machines visited. But the highest return rate was in Swan Hill. And again, a couple of reasons for that is some of the people that were involved with promoting the machine there were prominent members of their community in different social clubs or sporting clubs. So it was very easy to have people, convince them to do the test and return it. The other element with Swan Hill, and it was the only done in this location for a couple of reasons, was people had the option when they completed the test, if they went into this youth service, completed the test, they could actually just drop the completed test in a box, and the youth service would then take it and post it at the end of the day. So that's another thing that might increase the rate as opposed to somebody having to go find a post box. What we did do in Mildura, though, is we did have a map on the wall. In most of the other locations, the post box was within like eyesight, realistically, of where the locations were. But in Mildura, we actually put a map up, showed them in reference to where the community health was, where the Aboriginal Health Service was, where Officeworks, where KFC. So we have point of references and where the post box was. Realistically, I don't know if that really increased rates, but these are things that as we go through the evaluation and can ask these questions to community members, hopefully we'll get a bit more insight into what that actually, I think, looks like. And again, I think there'll be there'll be more questions than answers, which is normally the case for these types of pilots. But hopefully when we do the full evaluation and publish, we'll be able to delve a little bit deeper into some of the nuances between these sites. So the next steps, like I said, the evaluation is currently what we're doing. And then ultimately, depending on funding, what could it look like? Could we have a state rollout? Could we have a Commonwealth rollout? That's going to depend on money. Somebody has to pay for it. If Medicare decides to start allowing this as a reimbursable procedure, I guess, test, whatever you want to call it, then we could actually just easily add, we don't need to add anything to the machine because the machine would just have to be stock paid for by a service, but then the Medicare would cover obviously the return tests. So there'd be a little bit of wastage, but again, those costs are actually negligible in the grand scheme of things. The test kits cost roughly $20 some odd, and that's counting the Atomo as well in it. So there's a few things that would need to be unpacked, I think, a little bit further. And as I said, we really would like to have syphilis, and if we get the dried blood spot, we may be able to do Hep C or any of the other Heps realistically. New South Wales is already doing Hep C with HIV and dried blood spot. But our priority would really be syphilis as opposed to hepatitis, but it opens up a lot of options. So like I said, VIDRL, so the Victorian Infectious Disease Reference Laboratory, is working on dried blood spot, and we're part of that consulting group because we're really trying to advance this technology as fast as we can, because I think that's the future of making something like this. And that goes back to that question around how hot can the machines get? If it's dried blood spot, it doesn't matter because everything in there will now be dry. You won't have to rely on buffer solutions and whatnot that have to be at a somewhat temperature stable environment for long periods. And then ultimately, like I said, health promotion vending machines. It doesn't have to be sexual health products. We could put anything in these slots. If we wanted to put period products in one slot and an STI test in another, these machines go much, much, much bigger. This was literally just to hold enough for us to do a pilot. But when you're walking through an airport where you can get 50 different things out of a vending machine, you could do the exact same thing here. The benefit to these vending machines is ultimately we can track the information live. We have a live database. It's called VenLive, which is the British supplier's website, that we can track every time a test is dispensed, so we know in real time. I know when it gets low, so I can notify people to go restock it when it gets down to a threshold of like 2 or 3 tests left in any column. So there's so many things that you can do with interactive machines that with dumb machines, like they were using in South Australia, and I'm using dumb from a technology perspective, dumb machines that don't produce that live data. You have to have somebody that constantly can go check on it, which makes putting them in more remote or excessively rural locations a bit more difficult because you just don't have that real-time information. On the other hand, the downside of this is you do need to have some type of 3G. 3G is going out, so 4G capability. So one of the things we had to do in Mildura, just because of the location, we actually had to go get an external aerial and stick on top of it. So, I mean, not only did the ute that was going to deliver it have multiple external aerials, now the vending machine also needed its own external aerial to make sure that we are getting good service and not dropping. Because if the service drops out, the machine actually doesn't work because it won't generate the text code. So thank you. That's everything there and pretty much right on the time that I wanted to be. So that's great. So I'll stop sharing here again, and then happy to field any questions, comments, concerns I don't personally do complaints, so somebody else can handle those.
Thanks heaps, Dave. A couple of questions came into the chat just towards the end there. The first one was if you could please explain a bit more about the process for following up positive results and linkage to treatment and management.
Yeah, absolutely. So, sorry, I should have actually talked about that. So the process follows Test Me, which is Melbourne Sexual Health's, like I said, postal service. So it's that exact process. So in the kit, they fill in effectively like a little patient form. And then when that information goes back to Melbourne Sexual Health, the only lab that's actually approved in Victoria for postal samples is the Royal Children's, which seems a bit odd, but that's where all the tests go. And then those results get reported back to Melbourne Sexual Health, and then they have a nurse that then follows up. Now, generally, they had the no news is good news approach. The challenge with that on any postal service is how do you know whether or not you actually received the sample when it came back? So what we encourage people to do, even though it was a no news is good news approach, was if you haven't heard, and this was written a couple places in the instructions, if you haven't heard within 2 weeks, by all means, ring Melbourne Sexual Health and just ask for your result, because then you can know that they received the sample. I think moving forward, we really have to emphasize that we need to keep that that communication pathway open, so the information does have to come back so people can be assured that those tests were received, or when the test gets logged into the system that they get a text confirming that it's been received. A few other things that we could work out there kink wise. So those are things that were highlighted throughout the process. And in terms of the instructions, you can give me a second. Be right back. Just got to walk over to my bookcase. All right, so the instructions, I would hope weren't overly difficult. So, sorry, I can show you. So they had pictures, plain English, so easy. We couldn't translate. There's a couple of reasons why. And then if you notice, there's a little QR code up here in the corner. So we recorded videos. So if you couldn't work out the instructions, you could also watch the video on how to do any of the swabs. Atomo have their own videos and everything that people could look at. So yeah, if you're interested, you can even go on our search YouTube page. You'll see the videos, and you either see Kim's hands or my mouth, because nobody else wanted to volunteer to stick swabs in their throat for video purposes. So I got stuck doing that. So could it have contributed to low return rates? Possibly. But I think where we're moving to from, especially in the post-COVID era, with people understanding how self-testing works, it's a pretty straightforward process. I would be more concerned about getting false negatives of people doing it improperly as opposed to not doing it at all from confusion. But again, even then, we wouldn't actually know that unless we looked at the result and had heaps of negatives that they then followed up and had an immediate positive. So again, any type of self-testing makes that really challenging. And did we produce instructions for use or info about the pilot? Yeah, so in terms of the translation, no. And the reason for that was because it went to so many communities and there are different population groups within each of those communities. It just wasn't feasible for the pilot to do anything outside of English, which is why we went for the videos. So even if the language and the pictures didn't quite make sense, hopefully the videos could work. Again, it's not a foolproof method, but it was a way to effectively make it as straightforward as we could for this. Long term, if this were to get funding, then sure, any community that we were going to, we'd have to look at like the top few languages that might be spoken there and offer some type of translations, whether it all just sit on our website, because realistically, we wouldn't be able to put heaps and heaps of paper in for weight purposes and everything else. But it's definitely something that we considered. And the other question from Nicola was how effective was combining HIV test and STI test in one machine? So that goes back to the dual box dispensing. So ultimately, everybody got both. It wasn't, you couldn't pick one. You just got everything. So in terms of whether you actually completed it, that's, like I said, there's no way to track the HIV self-test. But everything was dual dispense. So yeah, same number of both tests. Thanks, Melanie, about the videos. Again, the number of takes that we did on those videos. I have to say, I never really expected to be using fake bottoms and vaginas to create videos. And I have a feeling it was really interesting. This bit of a funny aspect about this. When we first posted the videos, I don't know what people thought was going to be contained in the videos, but the vagina test video had 20 times more views than any of the other ones. So I don't know what people were looking on YouTube for, but ultimately I think they would have been thoroughly disappointed with the video because it was literally just an anatomical model. So in terms of the question around the HIV pretest counseling, so that's one of the things with the TGA requirements for Atomo. All we did was effectively provide that test. So that's why we couldn't unseal the box, because everything that the TGA approved in terms of the instructions, the follow-up, like if you have a question, these are the phone numbers that you can use. We supplemented that information with a website. So there was also so like these QR codes were stuck in. So the Atomo actually had a few other languages because they had already translated them for a couple of other reasons. But you could scan that QR code and go to a special website that we set up that would provide other information. But ultimately, we couldn't mess around with the contained information within the Atomo kit. So that's sort of the pre-test counseling. And I think there's an element now where we're trying to destigmatize these things. So making the testing more accessible, and it does highlight very clearly that these are very, 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 very sensitive tests. So you're more likely to get a false positive than a false negative. So therefore, don't panic. Go see a healthcare professional, and then you'll. Again, we know that the sensitivity and specificity are very good for this test. So if it comes back positive, you probably are positive. However, the reality is from lay communications is it's not always perfect. Just go see somebody, and this hopefully will be the push to get you to go do that. Yeah, in terms of the follow-up to MSHC, they were able to prescribe the antibiotics if necessary. So the people had options. So one, we said, if in your local community, we would like for you to go, if you're interested, you can go to anyone, whether it's one of the clinics, a GP, and tell them that you have the results because you would have received those from Mobile Sexual Health. Or if you weren't happy to do that in a small community, if it was chlamydia, which the only positive results that we actually got were chlamydia. And there was one instance where I know we did do this. They just posted the antibiotics out. Now, they wouldn't treat the partner at the same time. So it's a little bit different than what you would do in a clinical sense, face-to-face, but it gets the process rolling. And again, I think that also highlights things that we need to talk about moving forward around what standing orders look like and ultimately what the protocols should look like if we move to a more self-test type of process for STIs. Any other questions, comments?
Did have a really quick one, Dave, only just before I was taken away. Do you foresee that this program might actually present a bit of a blueprint to be introduced into at-risk government schools, if that sort of makes sense, where you sort of have a framework to say, here's a cookie cutter, put it in your school?
I would like to say yes, but I'll say that it's cost prohibitive at this present moment. So the vending machines themselves, when you factor in shipping and everything, are about $15,000. So you would need to have some really good investment to make that work, which is why ultimately we really wanted that community space where anybody can access it. In terms of what you could do in those spaces, again, obviously, if we were to buy like 1,000 of them, that price comes down considerably. Being able to have them locally made would also bring that down considerably. So we've reached out to a couple of local companies. No one here is willing to do it. So these are all things that effectively, if we wanted to move to that, there are some, I don't want to say dumb machines because they're a bit of a hybrid, but they still use spiral vend, whereas ours use like conveyor belt vend. They don't do conveyor belt vends here at all at this stage. They only do spiral vend. So if you can make the spiral vend work and the box is sat in there appropriately, those machines are quite a bit cheaper. So you could do something possibly in high risk environments. The challenge though, again, is I think it's probably going the other direction where you move to more of like a health promotion machine where there's 20 products in a machine. You can get whatever you want out of it because that also reduces the perceived stigma of walking and getting an STI test when you could actually just be going and getting, I don't know, a COVID test or something like that. And for Robin, no. So the results were you just need to ring Melbourne Sexual Health and they conveyed the results over the phone. Now there were ways ultimately to move to a text-based system. It just wasn't something for this that was really practical. I know when I worked for the National Chlamydia Screening Program in the NHS, all of our results were, well, negative results were text, positive results were call us. Whereas here it was no text was negative and a positive test was call us. So again, if you've had enough STI tests in your lifetime, you'd figure out that instead of call us, you have an STI. So that's sort of where they were at with the no news is good news. And it's just because they don't do a lot of negative testing, negative responses. And I think a lot of that just has to do with, again, and I've experienced this personally, again, working in another environment with people who might, someone might intercept that text message. Even though you generally don't put what it's for, you just say your test was negative. Again, you got to be very careful then if somebody picks up the phone and then they call and it's like, you have called Melbourne Sexual Health. It's an indication. Whereas in the UK, for the program I work for, if they phoned us, we just said, thank you for calling the NHS. What can we do for you effectively? And then they said, hey, I got a text. Well, then we could actually work out who they were and get all the information before we actually said it was an STI. So there's just a few things we'd have to work out if we're going to do that. Yes, in terms of interest from other places for local follow-up, absolutely. So we had in Mildura, where the sexual reproductive health hub is, most hubs were happy to do it. And as I said, of the 3 positives, 2 people went to local services, I believe, or sorry, 4 positives. I think 2 or 3 went to local services and 1 was posted. So people were happy to go to local places. Everyone local was more than happy to see clients to have that, face-to-face health promotion education conversation. But we also know that some of the reasons why people were using this is because they didn't actually want to go to a clinic. So it's trying to balance that, I think, as best we could. So yeah, there's absolutely a partnership there. This is never going to replace face-to-face appointments. It just gives other people a way to access something that they might not normally do otherwise. And over the phone, do you see it as better for client to present? So once they get the result over the phone, though, then information can be sent through like email and as a letter saying you have this, can you treat it? So like I said, Melbourne Sexual Health completely had this process down. So yeah, it would have still been provided as any formal information they needed, but at least at that point they were verifying the person before they gave any information, so that ultimately that result couldn't be intercepted by anybody.
Great. Thank you, Dave. That brings us to the end of our hour. Thank you so much for presenting, and thanks everyone for participating so much in that and asking so many questions. That was really great. Again, this was recorded and the recording will be made available in the next couple of weeks. Got lots of clappy hands going on. Thank you again to everyone, and I hope that you all enjoy the rest of your day. Bye.